Welcome, everyone. So we've just made it through our first half of the speaker series that was today. Thank you for joining us, and thank you to those of us who are continuing on with us into the second portion of our afternoon here. Our next presentation is with Dr. Moughamian. Dr. Armen Moughamian is a native of the Bay Area. He completed his undergraduate degree at the University of California, Berkeley, majoring in molecular and cell biology. He completed his medical training at the University of Pennsylvania, obtaining both an MD and a PhD in neuroscience through the Medical Scientist Training Program. He then returned to the Bay Area for an internship and residency in neurology at the University of California, San Francisco. After residency, he stayed at UCSF, where he completed a research fellowship in cognitive neurology and laboratory research. He joined the Ray Dolby Brain Health Center at the California Pacific Medical Center in San Francisco in January 2020, and he currently serves as its medical director. In this role, Dr. Moughamian leads a multidisciplinary team of physicians, social workers, and neuropsychologists to evaluate and treat patients with cognitive impairment and neurodegenerative disease, such as Alzheimer's disease. The team at the Dolby Center has pioneered a novel care model, which integrates a social worker into each visit to support and assist families and care partners of the patient. Dr. Moughamian is working to create a dementia care system within the Sutter Health Network, which spans a large portion of Northern California and serves more than 3 million patients. He is also an active researcher working on projects to improve the diagnosis, treatment, and management of patients with cognitive impairment. Today, he will be talking about healthy brain aging and the recent new medication approved by the FDA to treat Alzheimer's disease. So thank you for joining us, Dr. Moughamian. If you have slides, I've ended my screen sharing and you can take it away.
Perfect. Thank you, guys. Do you all hear me?
Yep.
Sounds good. You may hear a few kids in the background because I have a young baby in the back, but I really appreciate the opportunity to talk to the Cupertino Library about topic which I find extremely important. As you can see from the poll, that the majority of people do know somebody with cognitive impairment and Alzheimer's disease. And so I think it's really important to be able to talk about this. And I really appreciate that the Cupertino Library has put this front and center. So yeah, I work at the Ray Dolby Brain Health Center. I'm the medical director there, part of the San Francisco CPMC. Do you guys all see my slides?
Oh. Yes, we can see them.
Perfect. I signed in for the last couple minutes of your talk, and I think the one thing that came up that was really important was early diagnosis. I think this is extremely important, and we'll sort of emphasize that at the end. But early diagnosis of cognitive impairment is extremely beneficial, and I think can really help families and patients plan for the future, which and help manage the disease and the implications of it. So I wanted to start back a little bit. Like when we talk about cognitive neurology, when we talk about cognition, people tend to think, oh, this is just memory, but cognition is much more than memory, right? And so there obviously memory, which can even be broken up further into the ability to learn as well as retain information short-term and long-term. Executive function, things like attention, concentration, multitasking, visuospatial function, the ability to use a tool or to navigate your environment, recognize people. Language is a huge portion of what the brain does, understanding people, finding words, even behavior, right? Your ability to have depression, anxiety, changes in behavior, as well as changes in your motor and sensory function. And so my job as a cognitive neurologist is to kind of understand how these things have changed. So we want to understand what the baseline was and then how it's changed over time. And the interesting thing is that different cognitive functions localize to different parts of the brain, and different diseases of the brain impact these different diseases of the brain impact these different functions differently. And so we can sort of piece it together because we then understand what the cause of the cognitive impairment is that this patient is suffering with. And so what we first have to do is understand what is the stage of cognitive impairment. And cognitive impairments occur over many years, and often preclinical disease can start 10 to 20 years beforehand. I bring this up not to scare people, but I think it's important because you can think of a preclinical disease as a really important time for prevention, right? So part of my talk is to understand prevention and what we can do to reduce the impact of these diseases. And so there's a big window there in the front early on where we can impact patients and slow the disease down and improve healthy brain aging. And then in the prodromal phases of the disease, you can have a mild cognitive, you can have either a subjective impairment where people feel a little bit off, but when we test them, there's no real changes in function, cognitive function objectively. And then there's a mild cognitive impairment, which is that patients will have a mild, they'll feel a little bit off, or their spouse or loved one will say that they're a little bit off. But when we test them, there's some changes, but no functional impact. And that's a really important point about what we talk about with mild cognitive impairment, is that there's subjective changes, objective changes when we test somebody on a screening test, things like drawing a clock. There's standardized measures of cognitive function, neuropsychological measures, but no impact on function. So these patients are still doing their finances, they're managing their medications, they're driving, they're doing everything that they would have. They may rely on a calendar a little bit more. They've have to make modifications, but they're still doing all of the activities independently. Now, dementia is defined as now needing assistance with some activities, actually what we call the IADLs, or the instrumental activities of daily living. So dementia is symptoms of cognitive change in any of the domains that I talked about before, as well as objective changes. So when we measure somebody's cognition compared to what we would expect them for their age, there's a decline in both those aspects of subjective and objective. And now they're starting to struggle with things like finances and medications. They need a little bit of assistance from a loved one with that, right? So dementia, which I think is what Dana was talking about before, in some ways is defined not only as a disease that affects the patient, but absolutely affects the entire family, right? Because dementia is defined by the need for assistance with things you didn't need with before. So this disease impacts the entire family, care partner of the patient. And so it's really important to recognize the impact that it has on the family. And so now once we're in the stages of dementia, once we're in dementia, mild is defined as some assistance with IADLs that I talked about. Moderate dementia is defined as some assistance with activities of daily living. These are simpler things like grooming, toileting, bathing. And then severe dementia is defined by the need for assistance in all aspects of living. And so the next thing I want to sort of talk about is that dementia is not the same as Alzheimer's disease. And there's actually a distinction here. So you can think of what I talked about there at the top here as this is sort of the syndrome or stages of cognitive impairment. And then you have a diagnosis under that, right? So it's very similar to cancer, for example, where you don't just say somebody has cancer, they have a stage of cancer from 1 to 4, and a type of cancer, it's breast cancer or pancreatic cancer, etc. And it's very similar to what we talk about in cognitive impairment. So you have a stage of cognitive impairment, which could be a mild dementia or a mild cognitive impairment. Again, mild cognitive impairment defined as subjective and objective changes in cognition, but no functional impact, while a mild dementia is defined as having now a functional impact. And that is due to an underlying disease, right? So dementia is this umbrella diagnosis for which you have multiple diseases and causes under that. Alzheimer's disease tends to be the most common cause. So that's where this sort of lay public kind of synonymize these two, but they're distinct and it's important. Alzheimer's disease, I'm going to talk about in a minute, is a pathology, and all of these other causes tend to be different pathologies that accumulate in the brain. So, and these affect, as I talked about in my first slide, these affect different areas of the brain and cause different impact on cognitive function. So classically, Alzheimer's disease affects short-term memory early on. So these patients have difficulties with learning new material and they rapidly forget it. And that's due to an area of the brain that's affected in Alzheimer's disease. And Parkinson's disease patients can also develop cognitive problems. In vascular disease like stroke or small little bits of vascular disease, they develop different types of cognitive impairment. So an example here is that a patient has a mild cognitive impairment that's due to Alzheimer's disease. So mild cognitive impairment is the stage, and the underlying disease or pathology is Alzheimer's disease. And so what is Alzheimer's disease? As I said before, Alzheimer's disease is a pathology, right? It's the accumulation of pathological proteins. There's two of them in Alzheimer's disease. They're called amyloid beta and tau. And these accumulate in different regions of the brain over different time scales. And this results in loss of brain cells. And as brain cells degenerate, you have a cognitive impairment because the brain's not functioning as it used to. So the other lay term for these types of diseases are neurodegenerative diseases, or not, it's not a lay term, it's more of like a scientific term, but neurodegenerative disease, meaning neuron, which is the cells in the brain, degeneration, loss. So a neurodegenerative disease is a slowly progressive disease that accumulates over time and causes a loss of brain cells. What I show here on the right, I am going to try to show some data because I think it's important that we show data. I'll try not to show too much, but this is sort of a classic kind of thought on how Alzheimer's disease accumulates, that you get A beta first, then you develop tau later, and then you develop changes in brain on structural or on imaging, metabolic or structural imaging, and then here in the green, you develop cognitive symptoms. Again, I show this because this can actually occur 10 to 20 years before you develop any symptoms. But I do think that that is an important point to bring up because it can lead to interventions that you can think about that can potentially delay the impact of the cognitive impairment over time. And then what's highlighted here in the green area is that it's not necessarily linear, that different amounts of pathology can cause different levels of cognitive impairment, and that there's some level of resilience in any one individual's brain to the pathology. And so I think that's really important, again, to try to promote prevention and reduction of the impact of any accumulation of proteins over time, accumulation of pathology over time. And one other thing I wanted to mention is that very commonly, particularly in older adults as they get into their 80s, multiple pathologies are common. And I bring this also up because not to scare people that multiple things can be going on, but I think it's really important to realize, like, for example, in this Rush cohort, vascular disease in combination with Alzheimer's disease, as well as even other pathologies, this is most common. And so when we talk about prevention, probably one of the biggest points that we can really talk about is the treatment of vascular risk factors. I'm going to go into this in more detail, but treatment of vascular disease, particularly early in life, midlife, really important for long-term healthy aging of patients. So when we talk about prevention, what do we mean? And this is not necessarily from a dementia standpoint, but more from a sort of medical standpoint. So the goals of prevention are to reduce the burden of a disease on society and patient and reducing costs. We break prevention up into primary prevention. So this is how do we prevent the disease before it occurs versus secondary prevention, which is how do we reduce the burden of that disease on any one patient, early diagnosis and screening. So some other examples of primary prevention is vaccinations. Great example, right? You prevent the disease before it can happen. Versus secondary prevention, that's things like screening for breast cancer, colonoscopy, screening for colon cancer, or using aspirin for stroke or heart attack prevention. Now, when we talk about it in the setting of dementia, we're talking about, can we delay the accumulation of these pathologies in the brain, or which is primary prevention, or two, can we increase the resilience of people to these pathologies to try to lessen the burden of cognitive impairment of them, right? And so here are some different things that I'm going to get into a little bit more in detail. And then there's some ideas that both of these can happen, right? So we can treat vascular disease, which can reduce the impact on the brain, damage in the brain, preventing dementia, and other things can really try to maintain function. So treating hearing impairment, super important. Also, just recently in the news, can help you maximize the function of your brain. Okay. Now, I wanted to show this, and a lot of the data I'm going to show was put out in this Lancet Commission report. It's just about a year old. It came out in the summer of 2020, and this is probably one of the most comprehensive reports that talks about prevention of dementia and really sort of a meta-analysis of lots and lots of different studies on efficacy of different interventions for reducing the impact of dementia. And this, I think, is actually a really interesting slide. The details are the takeaway message here is that the age-specific incidence of dementia, meaning that the age of onset or the age of the burden of dementia has actually fallen when looking at these cohorts over time. So for example, we're comparing people on 10-year cohorts here in different studies from 70s to 80s or 90s to 2000s, and we're actually seeing that the incidence is falling. Now, that's contraindicated by, that's sort of, that doesn't mean that dementia is becoming less prevalent. It's just that it's happening later. Unfortunately, we're living longer. And so the rates of dementia, the overall numbers of people that have dementia are going up because people are living longer. And but at any one specific age, the incidence is going down. And this is thought to be due to improved education, nutrition, and overall health improvements, treatment of vascular disease, and improvements in lifestyle. So it is interesting, and it does show that prevention of dementia and reduction of the burden of dementia is possible. So that's really the main point, is that this is possible and actually been occurring. So, but how do we do it even better? And so this is sort of one of the summary bits from this paper that I was talking about, the Lancet Commission, and they break down things we can do to reduce the risk of dementia and cognitive impairment throughout life. And it's actually broken into early life, midlife, and late life. Early life, the biggest factor that we can work on is continuing education, early life education. Midlife, we talk about treating hearing loss, traumatic brain injury, hypertension, alcohol, and obesity, while in later life, thinking about smoking, depression, social isolation, physical inactivity, even things like air pollution and diabetes. This analysis said that about 40% of dementia, if you control all of these different factors, is preventable, which is pretty amazing. And so when we talk about prevention of dementia, I think it's two things. One is that earlier is better, but also it's never too late to really think about addressing these factors, and that prevention really is possible, at least at reducing some of the burden, right? So when we talk about prevention of dementia, it doesn't mean that there will never be any cognitive impairment. But when I showed that slide initially, maybe we can shift people into the mild cognitive impairment stage for longer periods of time, which really means that you have more functional independence for a longer period of time, improving quality of life, right? So we may not be able to completely prevent the disease from happening, but we can at least reduce the burden of the disease on any individual and try to get the most quality of life and the most independence to the patients over their lifespan. I'm going to kind of go into a few of these and show some data about these, the ones that I think are the most impactful and the most sort of interesting and treatable. The first one is early life education. I think this is really, really important. This is from the Framingham study, which is a classic heart study. And basically what they show down here and what I highlighted in red is that even just high school, right? So people that didn't graduate from high school had a higher incidence of dementia than those that completed high school. And there's other studies that show that the more education people get, the lower the likelihood of them having cognitive impairment. And this is thought to be due to a few different things. The idea of building up a cognitive reserve, that they have more, they've accessed their brain function in some way more, and they just have a better buffering ability to tolerate any pathology or changes in their brain. And so early life education, staying in school, high school, college, graduate school, and that actually doesn't just stop in early life, but continuing education, continuing to stay cognitively active for as long as possible throughout your life is important. So this even relates into later life, that when people retire, they need to stay cognitively active, and I'm going to address that in the future, in future slides here. Next is hearing loss. So this actually came up in the news recently. Biden was talking about being able to lower the cost of hearing aids, which I strongly support. They're very expensive, and they're a known, hearing loss is a known factor that influences cognitive impairment. And so again, I don't really need to get into the data. It's there if anybody wants to kind of get at it. But the main point is that people that have hearing loss tend to have poor cognition on multiple domains, tends to be a little bit more in the executive domain. That doesn't really matter in the context of what we're talking about today, but hearing loss is associated with poor cognitive performance. And that if you use a hearing aid and you improve your hearing, you actually improve your cognitive performance. And so this study was looking at those that used a hearing aid versus those that didn't, and those that used a hearing aid tended to do better than those that didn't. And one thought was like, oh, this is isolation, and social isolation does tend to mediate some of this effect in people that aren't treated with their hearing loss, but it doesn't explain everything. And it's clear that treating hearing loss can lead to improved cognitive performance. So hopefully, as what Biden was talking about, is if we lower the cost of those hearing aids, it'll make it more accessible. I would say that treatment of hearing loss early is quite important. There is an adjustment that if I've noticed in my own sort of anecdotal clinical practice, that if people wait too long to treat the hearing loss, they don't tolerate the hearing aids as well. And so I think treatment in the mild to moderate stages of hearing loss early, allowing people to get used to the hearing aids, improves outcomes, and it just creates better tolerability. One other thing is depression. I think this is a really important factor. Again, a little bit complicated of a slide, but depression, and particularly people that develop depression later in life, is a risk factor for cognitive decline. It's a little bit of a debated mechanism about whether that depression is the earliest manifestations of the cognitive disorder or the disease, or whether it's just creating a vulnerability in the brain that's then taking over and then allowing the disease to set in. But we do see, like, for example, here on the right, in patients that have dementia, you see rates of depression increasing anywhere from about 10 to 10 years, starting around 10 years prior to the diagnosis of dementia. You see that the rates are increasing of depression as opposed to those that didn't have dementia. They tend to have the same rates. So it sort of precedes the onset of the dementia. And this study is kind of another interesting longitudinal study that looked at people that had depression, and that those that had early life depressive episodes didn't necessarily have a higher rate of cognitive impairment, but that those that had later life depression, that never had an episode of anxiety, depression, affective disorder, but then develop it later in life, are at a higher risk of developing cognitive impairment. So I think it's something to for you to take away from that is it's important to kind of recognize this in your fellow friends, yourselves, bring it up to physicians. I think when I talk to primary care doctors a lot, I say that this is a really important warning sign, so that if you have a patient that develops depression, if you have a loved one that's newly developing depression, I think it makes you kind of think a little bit more. Do they have, is that the earliest manifestations of a memory change? Should we be worried about memory in this patient moving forward, and keep a closer eye on them. Hypertension, I think this is actually probably one of the most important factors for reducing development of damage in the brain, and treatment of high blood pressure is super, super important, and something that really needs to be done in as soon as you develop high blood pressure. These are two different studies. Again, details don't necessarily matter. The study on the right looked at incidence with a blood pressure of greater than the top number, systolic blood pressure of greater than 140. The bottom study here looked at if you can treat it at less than 120, you actually do even better. Midlife hypertension causes vascular disease in the brain, causes people to have what we call increased white matter hyperintensities. It doesn't necessarily matter here again for this context, but you're basically developing damage in the brain, which can slow thinking over time. A little bit here or there doesn't matter, but it's the accumulation chronically over 20 years of high blood pressure. It causes shrinkage of the brain and accumulation of sort of damage to the connections of the brain. So treatment of high blood pressure is super, super, super important. I recommend that blood pressure should be, midlife, maybe more normalized. So around 120. In older adults, that aggressive blood pressure can be detrimental, increased risk of falls and things. So you can back off a little bit, maybe more towards 130 in older adults. Obviously, it depends more on their comorbidities, maybe up to 140, but definitely below 140 or closer to 130 of the systolic, which is the top number. Now, this is intentionally really small. So this is cognitive training. So there's a bunch of really small studies of different types of interventions that people can do to improve their brain function. So people sell all sorts of different apps and things, and some people will say, oh, it's crosswords or Sudoku or whatever. The reality is that all of these studies are actually really small and pretty poorly done. But the important thing here is that all of these studies show benefit, right? So the individual studies here don't necessarily matter, but all of these studies show that the intervention of whatever this cognitive training activity was is better than not, right? And so all the studies show the trend towards improvement, but the specific intervention doesn't matter. It's really important to stay cognitively active, right? So this gets back to the early education, but continuing education, particularly once you retire, you're maybe not as cognitively demanding tasks, but it's important to find something that you enjoy. And why do I say that it's important to find something you enjoy? Is that if you enjoy it, you'll do it, right? So I hate crosswords. My wife loves crosswords. I will never do crosswords. I'm just not going to do them because I don't enjoy them. But I enjoy other things, other types of activities, reading, etc. So those things are really important. And if you like puzzles, you like math games, things like that, do those types of things. It's important to engage your mind in activities. There's also some evidence to say that things that cause kind of new learning, so that you're not just doing the same thing over and over again, but things that can kind of morph or change and challenge people in certain ways, super important. But there's not necessarily one app or one intervention that's better than others. Just find something that you enjoy and that you do. The other important thing about finding something that you enjoy is that, all of this should be trying to improve quality of life. And if we make you miserable by doing something that you don't like doing, I don't think we're actually making, even if we lower your risk of dementia, I don't think we're actually making headway there. So again, finding something that you enjoy that keeps your mind active, it's not just sitting there and watching TV, but trying to produce something out of your mind and think, super important. But the specifics don't necessarily matter. Okay. Now, one thing is to transition into diet. So this study looked at a Mediterranean diet versus a control diet and showed that there's an improvement in cognitive function compared to those that were on a control diet. The WHO, the World Health Organization, recommends a Mediterranean diet, which is higher in fruits and vegetables, legumes, which are like beans, nuts, whole grains, but lower in saturated fats and kind of red meats. Leaner meats, things like chicken and fish, are better. There's no evidence that any vitamins, supplements, oils, etc., preserve or improve cognitive function. There's a lot of people that will tell you a lot of things, and there's really no good evidence that any of it has any positive effect. Obviously, if you're low in things like B12, that should be treated, but taking excessive amounts of vitamins has not been shown to be effective at reducing the impact of reducing dementia or improving cognitive function. I think a daily multivitamin is fine. Things like vitamin D for bone health are separate. We're talking specifically about cognitive health. So I don't recommend that anybody goes on any vitamins or supplements. And I think there's actually a lot of ability for people to get taken advantage of, because this is a pretty unregulated area of medicine. So a healthy diet, maybe a multivitamin, if that's something you're interested in, is really what we recommended. And I say just to sort of stay away from supplements. They can be really expensive, unregulated, and really no proven benefit in well-done trials to show any improvement in cognitive function or the delay of cognitive impairment. And I'd be happy to talk about that further in questions. Any of this, obviously, ask me questions. One other diet is this MIND diet. This was developed by some researchers in the Midwest. This is one, I stole this off the internet, that talks about it. It's basically what they call it's a combination of the Mediterranean diet and the DASH diet, and they call it the MIND diet. And it's basically a Mediterranean diet, but they add in a little bit more olive oil. They add in berries as the main fruit. The thought there is some antioxidants. And it's actually been studied and shown to be effective. This is a simplified diagram. The slides will likely be available, so I'm just throwing it up there for you. Again, high in fruits and vegetables. The MIND diet tends to focus on berries as the main vegetables, lots of green leafy vegetables, nuts, olive oil for your main kind of cooking oil, fish and poultry, staying away from red meats, about 5 ounces of red wine per day are okay, and then whole grains and beans, but staying away from saturated fats and dairy, things like cheese and butter, and fried foods. Here's a more complicated diagram, also kind of taken off the internet. As I was making this talk, this gets a little bit more into the nuts and bolts of the amounts of these different components. Again, trying to limit red meats. It doesn't mean you can't have it. It's just trying to stay away from it. You're not having red meat with every meal. Again, all about quality of life, right? So if you live this very stoic diet, but you're not very happy, I don't think we're actually gaining much, right? So everything's a risk benefit here. And the effects on diet are not nothing, but they're not like gonna completely reverse any dementia. So I think it's an important component, but again, quality of life is important. So, it's a balance between what you enjoy in your life, but also keeping yourself healthy and getting the most quality and quantity of life. So again, this will be available in the slides. I don't necessarily need to go into the full details. You can read it for yourself at your leisure. And again, it's just really about the MIND diet. So if you Googled that, you'll see these types of things going forward. Now, this is important. This is another important bit of data that I wanted to share, that these effects are actually additive, right? So when we talk about prevention, those that followed more healthy physical activity, so about 150 minutes of activities, this is something that gets your heart rate up, followed a better diet, stayed cognitively active, didn't smoke and didn't drink much, tended to do better than those that did all of these, right? So, and these are additive. So here, the number of healthy lifestyles you had, the more of these sort of 5 factors that you followed, the better you did in these 2 different cohorts. So the CHAP and MAP are these different cohorts. The details don't matter, but the point of this slide is that every little bit counts. And so all of these factors are additive, right? So important to, I always recommend 150 minutes a week, divided up as much as you would like. So that's 5 times 30 minutes, or about 20 times 7, 20 minutes a day, a little over 20 minutes a day of something that gets your heart rate up. I think it's important that it's cardiovascular. And I think the really important point to take from this is that what's good for your heart is good for your brain. And so all of the things that you guys have read and heard about for reduction of cardiovascular risk, improving heart function, all of that applies to cognitive function and improving, you're reducing your risk of dementia and cognitive decline later in life. So what's good for the heart is good for the brain, and that many of these things are additive, and that the more you can do, the better off you are. So that's the point of this here. Now we're getting even more, so all of the data that I've shown you so far has been sort of association studies. So these are cohorts of people that are volunteers that sort of give data about their life, and we watch them over time. But this trial, called the FINGER trial, which was actually done in Finland, looked, can we improve cognitive function moving forward with lifestyle interventions? So it's what we call an interventional trial, where they started people at time 0, told some people got a sort of a 2-year trial, and they were randomized to either getting just a general health advice or a very a sort of regimented, prescribed sort of routine of diet, exercise, cognitive training, and vascular risk factor monitoring. And then these patients were followed over 2 years. And those that did this, the intervention, which was the diet, the exercise, the cognitive training, again, things that just kept your mind active, treated high blood pressure, reduced smoking. The diet here was very similar to the MIND diet or Mediterranean diet, had about 150 minutes of exercise per week. Those people actually did better, right? So these are the deviation of scores, and that the interventional group did better. And this is a total cognitive function. Here's executive function, processing speed. So they were thinking a little bit faster. Executive function, if you don't remember from my initial slide, things like attention, concentration, multitasking, didn't necessarily have an effect on memory, but overall had an effect on function. Now, this was a smallish, not actually that small, but a regional study in Finland. We're now, as a community of in Alzheimer's and cognitive disorders, are spreading this further on. So there's a worldwide Fingers initiative, and there's also a trial in the United States that's funded by the Alzheimer's Association called the US Pointer Trial, that's doing very similar lifestyle interventions and looking at, can we reduce the impact of cognitive impact with these different lifestyle interventions. So a prospective study as opposed to looking backwards at it, which is a higher quality of evidence. And so I think I'm really looking forward to these studies, which will provide more evidence to really trying to encourage people to do things that can improve their cognition. So to summarize, these are probably the two more important slides about talking about the actual interventions that are recommended for the reduction of dementia and cognitive impairment, treating blood pressure to a systolic of less than 130, particularly in midlife, the use of hearing aids, discouraging alcohol, less than 21 drinks. That's a lot. I tend to say following the CDC guidelines. So that's 2 drinks a day for men and 1 drink per day for women. That's not only for cognition, but also for reducing the risk of falls and other injuries. As people get older, they get more vulnerable to the sedating effects of the alcohol, can increase the risk of falls. Falls can cause things like fractures and head injuries, which can only worsen quality of life. Again, as the fourth thing down there is reducing the head trauma, so wearing helmets when you're out on a bike or a skateboard, stopping smoking, reducing obesity, and staying physically active. Again, my recommendation is about 150 minutes a week, something that gets your heart rate up. Walking is totally fine. You don't have to run a marathon, but you have to get out and you have to move. For people that have balance issues, I like using a sit-down bike. I think that can be really helpful. It can get your heart rate up, you get you moving, and it helps you if you have balance issues or mobility issues. A bike can be really helpful if you have knee pain, for example. As a sort of population-wise, I think this is important from sort of a political and societal standpoint. Things that we can all think about is, prioritizing education. That we can all make sure that people get a good education. That's not only good for their sort of economic and social economic lifestyle and improvement, but also that it reduces the impact of cognitive impairment later in life. Prioritizing ways to treat hypertension, developing systems to encourage social, cognitive, physical activity, reducing the cost of hearing aids. So Biden got that one. Hopefully it goes through. And then just finding ways I didn't really get into the air pollution, but I think that's also really important, and national programs to reduce smoking. All of these are really important measures that we can do to reduce the impact of cognitive impairment. So I'm going to transition now onto the treatment of cognitive impairment and dementia. On purpose, the top thing there are non-pharmacological behavioral and safety interventions. And so I think this is very often people talk about, oh, it's dementia, there's nothing to do. That's totally not true. I think there's a lot of things that we can do, and something that we work really hard in our clinic, particularly with my social work team, is helping caregivers and families adjust around patients with cognitive impairment. And there are many things that you can do to improve quality of life of the caregiver as well as the patient. You know, we don't ask somebody with a broken leg, why aren't you walking on your leg, right? So it doesn't really help somebody that has a memory problem to say, oh, why are you repeating yourself? Or why are you saying that again? You just said that. It's sort of, they have a disease, right? I think the first thing is to recognize that cognitive impairment is a disease, and it's not they're intentionally forgetting or they're intentionally repeating themselves, but that there's a disease process going on, and we should be kind to one another, and just sort of recognizing what's going on and working with each other. So there's lots of different interventions that we can do to help families and patients adjust around this and improve safety, right? So this is where early diagnosis is really important, right? Because dementia is defined as the loss of the ability to do something, right? So with that, there could be mistakes in medications, there could be mistakes in finances. If we diagnose people in the mild cognitive impairment stage, that's preventative. We can create areas of safety around patients, a little bit more oversight of medications, oversight of finances, and hopefully reduce any impact that the progressive cognitive decline has on their overall quality of life and future well-being. So really important to have early diagnosis so that we can create areas of safety, work with families to develop a plan on, you know, these diseases progress slowly. I didn't mention that, but these are very slowly progressive diseases. We have lots of time, but people often wait too long. And so it's important to recognize this early, talk to physicians early so that we can try to create systems that prevent any impact of these diseases. There also are medications that we can use to talk about to treat cognitive impairment. Sort of divided here into cognitive medications. These are modestly effective, so I very often tell patients it tunes the edges. It sort of helps a little bit with memory, a little bit with word finding, a little bit with attention, things like that. The main one is a cholinesterase inhibitor. This is things like donepezil, which is also known as Aricept, but there's two other medications. And again, they're about equally effective, and they're effective throughout the disease. You know, again, a little bit beneficial. Memantine is something that's added in the moderate to severe stages of dementia, maybe not even quite as effective as the cholinesterase inhibitors, but it's improved. It's been studied in large patient populations that those that were on it did better than those that weren't, and so I tend to use it. The cholinesterase inhibitors can cause diarrhea, nausea, main side effect. Memantine's pretty well tolerated. Sometimes people get a little bit of dizziness or headache. And then there's medications that we use for other types of symptoms that can come on with dementia, things like mood changes, irritability, and agitation. And there's a few different medications that we can use. Again, we always prioritize non-pharmacological interventions. What can we do to create a more, a better environment for patients to reduce any of those symptoms? Often sleep changes can also occur. But again, pharmacological interventions are secondary to non-pharmacological interventions, but sometimes are necessary depending on the severity of the symptom. So this is where we were with treatment of dementia and cognitive impairment until about a month ago. So a new medication, which you probably all have heard about in the news, it was pretty big news. It is controversial, so I'm going to try to talk about it. Here again, I'm just kind of giving you the information that's public knowledge. This is not at all an endorsement of this medication. This is just to give you some insight and a little bit of my opinion about the medication. So on June 7th, the FDA, which is the US Food and Drug Administration, approved the first medication, a new medication called aducanumab for the treatment of Alzheimer's disease. And this is the first medication that tries to address the underlying pathology of the disease. The medication is pretty clearly does reduce the amount of pathology in the brain. It clears amyloid, and it does that pretty well. There's no controversy around that. The medication is a monthly infusion, so this is not an oral medication. It's a medication that you have to go to the hospital for, get an IV, get an infusion of this every month. It was studied for 78 weeks, so about a year and a half, but you know, maybe even longer than that patients are on. Honestly, we're not quite sure how long patients have to be treated for it. And it was studied in patients that have mild cognitive impairment. So this is mild cognitive changes, objective and subjective changes in cognition, but no functional declines. They're still independent, and that they had confirmed amyloid pathology. I didn't get into the diagnosis of Alzheimer's disease, but there are ways to prove that people have amyloid pathology in their brain. If people have questions, I can ask at the end. But the controversy really comes down to that although the amyloid was cleared from the brain, there was not a clear benefit on cognition. So there were two trials that were done in parallel. One trial showed a slowing of cognitive decline by about 22% over 78 weeks. And this was on standardized measures that are used in many trials for Alzheimer's disease, but it slowed the decline down by about 22%. So a quarter, which is pretty good, right? I mean, if you think about extrapolating that over the time, again, that's an extrapolation that does, potentially improve patients' function over time and give them more independence over time. The other clinical trial showed absolutely no effect. It didn't cause any improvement and it didn't cause any decline. It was just totally neutral, right? So the controversy comes that you have one trial that's positive and one trial that's negative. So scientifically, there's no question that the right thing to do would have been a third trial. The FDA's decision, though, was to approve the medication under an accelerated use and ask for a third trial once it's approved. So, it is what it is. It is their decision. This medication is now available. I think my opinion is the following. One, I think this is an exciting step for Alzheimer's disease, that we are now getting towards treatment of the underlying pathology. This medication is definitely not a cure, but I think it's a positive step forward. It is going to be appropriate for a very specific group of people after a sort of a lengthy conversation with your physician. It is really only for people that I would really only use this in people that fit that clinical trial, that were a mild cognitive impairment, confirmed pathology in the brain. I think the most important thing here, and this has been sort of a theme that we talked about even from Dana's talk, is that this medication now incentivizes earlier diagnosis and detection. So we can try to capture people earlier, capture them before they get dementia, so we can create safety around them, improve quality of life. Whether or not they go on the medication, I don't think is as important as early diagnosis and detection, because I do think that that does improve quality of life and for patients and families. And so I think it's really important that we can incentivize that. And this medication does incentivize it. Whether or not people decide to go on that medication is a very personal decision. But I think from a system standpoint, we really need to start trying to diagnose people earlier and earlier. So I wanted to try to leave a lot of time for questions. So I turn the floor over to you guys to ask me some questions.
Wow, that's quite a bit of information you've given us, Doctor. Yeah, I think that this is going to be a good reason for people to rewatch the video.
Sorry, I don't know if I talked too quickly. I'm sorry.
No, it's great.
Cover,
I mean, this is great. I mean, this is a place, you've been able to give us information that's really very helpful. There are a number of questions that have come up. So I'm just going to kind of go through a few of them. One of them was a question: does untreated sleep apnea also affect the brain?
Absolutely. Yeah. So I think it's definitely a modifiable factor. So whenever somebody comes into my clinic, you always think about what can we treat and what can we modify to improve quality of life. Obstructive sleep apnea has definitely been shown to slow cognition, particularly executive function, attention, multitasking, concentration, and treatment of it improves function. So often there's a bit of a warm-up period to getting used to the machine, but those that can tolerate it tend to do better, particularly those that have severe sleep apnea. So again, reiterating, what's good for the heart is good for the brain. So obstructive sleep apnea can definitely lead to hypertension, heart problems, lung problems, but it also leads to cognitive problems. And so treatment of underlying other medical comorbidities of like sleep apnea, definitely a good idea and can improve cognitive function and outcomes.
As you were saying that, it also struck me as something else that people have said affects many other things like hypertension and everything, is stress. I know that stress can come from other things, particularly if your spouse doesn't like your CPAP machine making noise. But is stress also one of those things that we can try to address as reducing the risk factors?
Yeah, I will say it's a more of an so I kind of avoided that a little bit today because there's stress is something that's really hard to measure. And so there's not a lot of good studies to talk about it. In my own empiric practice and from what I see is that people that have underlying stress definitely struggle and can have cognitive impacts. So I think I don't have hard data to show you, but I think that trying to find ways to relax and decompress and find outlets for your stress is important for your brain function. I think that's clear. I just don't have strong data to support it. And I think treatment and finding people to talk with is really good to really reduce stress and burden of cognitive impairment.
You know, another question that came on very early in your talk was about day programs and whether they slow down dementia or do they relieve symptoms, and what studies might they have on how day programs would fit in?
I think day programs are fantastic because day programs provide cognitive stimulation to patients. So I think that's very clear. It provides social stimulation for patients. It provides sort of respite for caregivers, right? So otherwise the caregiver is having to provide that kind of level of stimulation, but now a caregiver or a partner, a child, whoever that care partner is, can take somebody to a day program. That patient can get the positive aspects of the day program, and the partner can get some respite. So they can go to the grocery store, they can go to the gym themselves. So I think day programs are really, really important. Here, for example, in San Francisco, we have things like the Institute on Aging, but even things like senior centers locally down in the peninsula where you guys live, I think is fantastic. And I encourage people to explore them, and I encourage our sort of county governments to make them affordable, because that's always an issue.
And you also mentioned that for everyone, doing things like continuing education can help with, even if you're at very early stages.
Yeah, I agree. Community college, learning a foreign language, anything. I think you just have to find what you're passionate about and something that you enjoy and go for it.
And of course, coming from the Library Foundation, you should always visit your local library and talk to your librarians. They're the most wonderful people in the world. There were a bunch of different questions on the new drug. I can't pronounce it, but one of the things was on what are the costs like for that, and does Medicare cover it? And is it effective for only for earlier diagnosed dementia, or it could be for someone who's been diagnosed for 5 years or more?
So the costs, this is part of the controversy. So Biogen is the company that put out the medication. The sticker price is $56,000 a year. That does not even include the cost of an infusion, right? So there's going to be a hospital-based charge for the nurse's time, et cetera, in using the facility to put the medication in. We are still figuring out what's going on. I actually don't really even quite know yet. I've been working with the company and working with different Medicare and other private insurers to understand what the costs are. I think this is a really, really important thing, that before we start any medication, everybody should know what their upfront cost is. And it's also a sort of health equity issue. So it's a moving target, right? It's only been out for a month. I'm not quite sure right now. I think a lot of the people that have gotten infused already are paying cash. Not that many people have gotten infused. And so it is expensive, and I think Medicare will be paying for it, but it's a little bit unclear. And there's always this, your supplemental has to somehow get into that. So otherwise you're paying 20%. So that, I just don't have a lot of information yet, and we're still trying to gather it. Now, regarding time to diagnosis actually doesn't really matter. I would say if you are still in the mild cognitive impairment stage and you have confirmed amyloid pathology in your brain, you would be considered eligible. Now, once you get into mild dementia or moderate or severe dementia, I would not recommend this medication. It has not been studied at all. So we just have no data to support the use of it. And I think it's soft enough data in the mild cognitive impairment stage that I would not really prescribe it in people that have the diagnosis of dementia. I would really just focus on mild cognitive impairment. And the idea is that we're slowing the disease down. This is not a reversal. It's just sort of bending the curve and slowing it down. So really no recommendation for using it in people that have a dementia diagnosis. But the time from, if you were discovered really early and you're still in the mild cognitive impairment stage, you still would be considered potentially for the medication.
Cool. I remember very clearly what one of our attendees has suggested, that there's an issue with possible copper. I remember the aluminum pan scare from 20 years ago or so that said you shouldn't cook any of your food in aluminum. And the attendees said that they've read that they suggest only using bottled water versus tap water because of possible issues with copper. Is this myth, or is this something that they should be worried about?
I don't know the specifics around the aluminum. I think in the Bay Area, well, so water toxicity, I think the biggest issue is lead. We don't necessarily have that issue as much. I don't know. I mean, overall, I think the water quality in the Bay Area is like some of the best in the country. So lead for sure. If people have lead pipes, like in the Midwest, we talk about like Detroit and things with lead pipes, definitely a problem, and you should avoid it. I think, in my opinion, the water quality in the Bay Area is quite high, and it's fine to drink tap water. There are heavy metal toxicities that can contribute to cognitive impairment. Things like welders that have been, having that metal kind of melt and it gets into them. I think on normal consumption, I don't think it's a huge issue that you need to worry about.
Okay, we got a technical question. Is the association of cognitive impairment with education causal or correlational?
So it is a good question. I actually have a slide in here, but it's going to be a little bit hard to find, that there is evidence that those that were followed over time that have higher education actually have lower amounts of amyloid in their brain. So that does suggest that somehow people that have higher levels of education have less pathology. And it's not just that they were a little bit smarter and developed some resilience to the brain, like they were somehow better, and so they went higher in education, and therefore their brain is stronger and less resilient. I think it's probably a little bit of that. It's probably a little bit of both, but there is some evidence that higher education actually can reduce the pathology in the brain modestly.
Okay. I recall a speaker from a few years ago who was talking about Alzheimer's disease, and she mentioned that in the nun study, they found that there was a particular group of nuns who had, when they died, their brains definitely showed Alzheimer's disease, but they had far fewer of the indicators of the disease, and that these were highly social nuns, especially ones that were still going out into the villages and teaching. Is that true, or is it?
Yeah, no, there are people that we're seeing this. There's the religious order studies, which is I think what you're talking about. There's also this 90 plus cohort, which is another aging study based, I think, out of Irvine, but it's throughout the country, that's showing that there are these super agers, that there are people that can have the pathology in their brain and doing fine. And so that is a really important point, and I think emphasizes that you can do things to your that can reduce that. So for example, I can't look at somebody's MRI and say this is what their cognition is. There's not a one-to-one correlation between the amount of brain and cognitive function. There's a buffer, and so there can be people that have a lot of pathology in their brain and they're doing fantastically. And so the idea is that some of these preventative measures can reduce the outward manifestation of the pathology. And so being social, staying active cognitively, physically, socially, all of those things do improve function, right? It's not 100%, it's not going to do it for everybody, but I think those that do tend to do better than those that don't.
Once again, go to your public library, go to your schools, A couple of the attendees just wrote in and said, you know, be careful with the bottled water just because of the plastics, and because you know you may have one problem and lead to a different one. I got time probably for one last question. It's another technical one. What's the difference between BPSD and Alzheimer's disease, and how is BPSD treated or managed?
PSD?
Yes.
I actually don't know what BPSD is.
I can't
Sorry,
help you there. That's just what I got in
Okay.
the thing.
I'm gonna skip it because I'm trying to be bipolar. No, I don't know. BP. There are some other diseases that look like Alzheimer's disease, things like hippocampal sclerosis of aging, or this thing called late, and that's why amyloid pathology is really important for confirming. But BPSD does not ring a bell, and I apologize.
Right. Well, if there's anyone else that has a question, if you want to raise your hand, I can get you online, or else just type it into the thing. So going once. Well, with that, I want to thank you, Dr. Moughamian, and also to Dana. And we would like to actually run an exit poll at this time. Sitha, can you bring that poll up for us? In the meantime, I'll see if there are any other questions.
Henry, there was a question that Roma sent to me during my chat. I'm sorry, I just had to take Hope out real quick because she was starting to bug me a bit. So there was a question to define what an assisted living waiver is.
Yes.
And I briefly touched on it a little bit during my talk, and I might have misspoke a little bit. So the assisted living waiver program through California Department of Health Services, the point of it is to make affordable housing available with personal and health related services to seniors and individuals with disabilities. So it's an alternative to long-term care placement in a nursing home. And it specifically assists Medi-Cal beneficiaries in remaining in their community. Cool. So looks like it's available in certain counties.
That's a California program, it sounds like.
Yeah, yep.
Okay, so we should go online and look for that if you should, you know.
Yes, so it's available, it looks like San Francisco and Santa Clara counties among the other lists, but those are kind of local to, you know, the group that we anticipate as part of our attendees today. And it's available through eligible individuals that are enrolled in Medi-Cal and meet the level of care provided in a nursing facility. So,
okay, well, I'd like to thank both of our speakers very, very much. I mean, I'm just looking at the poll results, and everybody was very happy. We had approximately 80 people attending today, and I want to have the community also continue to reach out. And one of the things I would have, you know, when I talked with Dr. Moughamian before about this is talk to your doctor. Yeah. You know, I agree. Reach out to your doctor. If you have issues and stresses and everything in your family, seek help. Go talk to your religious leader. Go talk to your friends. Don't try to just do it all on your own, right? This is something that is a team effort. So do it. I want to also bring up that, you know, we do have 2 more talks immediately scheduled in this series. 2 weeks from now is on the Alzheimer's, and the Alzheimer's Association is going to come talk. And 2 weeks after that, on August 8th, we're going to have your fellow residents come and talk. And I think that's going to be extremely informative to understand what people are going through it and have been through it, can give you perspective on. And as I say, in September, we're going to try to have one on financing, try to understand this. I would like to also thank our sponsors, the Forum Health Fund, the Dolby Brain Health Center. I'm getting tongue-tied here. The Forum at Rancho San Antonio, and also once again, the City of Cupertino has recently given us a grant to start the Get Set Up program for other educational things. So Library Foundation will be bringing you additional educational opportunities aimed specifically at seniors. So once again, thank you all very much. And